Good afternoon, everyone. Welcome to our Conversations of Hope. My name is Roxana Trejo. I'm the Senior Director of Nursing here at Community of Hope. Just want to go over a couple of logistics for our webinar today. So this is a Zoom webinar. We are recording this webinar, and we will share the link after the event in case you want to share it or rewatch it. The other piece that's important to keep in mind is that everyone will be muted throughout the conversation today. And that also means that the panelists, guests, cannot see your images. So our program today includes introductions, an organizational overview from Kelly, and then conversations with our program manager, the community health worker, employee, and then we also have a very special guest who is a program participant in our conversation today. We will also have a Q&A session at the end, and you are all welcome to post your questions on the Q&A chat, and we will review them and hopefully get someone to reply in real time. There's a lot to look forward to in the next hour, and thank you again for joining. Now let me take a moment to welcome our President and CEO, Kelly Sweeney McShane, to the conversation. Hi, Kelly.
Hi, Roxana. Thank you so much to everyone who's joining us today. So I'm just going to take a few minutes to do a little context setting before we get into the meat of the conversation around community health workers. So Community of Hope's mission is to improve health and to end family homelessness in order to make Washington, D.C. more equitable. And in 2023, we served about 20,000 people across all of our different programs. We served over 1,700 households in our programs that support people experiencing homelessness. And we're not going to talk about that a lot today, but I do want to make a mention that we're serving more individuals in our homelessness services. And a lot of those have chronic diseases, and we're going to talk a lot about that today. In healthcare, we served almost 16,000 patients across all of our different health centers. And we're a majority in wards 5, 7, and 8, and provided over 80,000 visits. Community of Hope, in terms of where our services are located, are intentionally located in communities where there are large disparities in health outcomes. We provide a full range of services, everything from medical and dental care, emotional wellness, and increasingly over the years, other supportive services. Data has really shown that improving healthcare is driven by so much more than just a visit to a doctor's. There are so many social determinants of health that impact people's health. That includes access to food, safe environments to work and play, income, stable housing, all those different components. And that has what's really led us to invest in models such as the Community Health Worker Program. These are really critical components to help our staff get out of the clinics and into homes and into communities, and to really support patients where they are. We are so grateful to the DC Health for issuing a grant to support this pilot project around community health workers. We have learned a lot, and as you will hear, we're really seeing an impact, both in terms of improving people's lives as well as in specific outcomes. The lingering question, of course, is long-term sustainability and how to bring this to scale. Unfortunately, community health workers right now are not covered by Medicaid or insurances, and that is something that we think is really important from a policy perspective. We've used philanthropy and government grants to get these programs started, but we're also really advocating for changes in payments within Medicaid. We still have ways to go. Looking forward to continue conversations with our partners at Department of Healthcare Finance, and that will continue. We'll talk a little bit more at the end. I do just want to say we have just put up a slide that shows a little bit of our services and where we are throughout the District of Columbia. You'll see the purple shading is where our patients live. So really in kind of the northwest, 14th Street, Georgia Avenue corridor, where we grew up more than 40 years ago. But then, as you'll see, significant number of patients in wards 5, 7, and 8. The orange dots are where our locations are, and then the purple dots are where we support people in their own apartments throughout the city with housing and supportive services. And then just one more slide just to emphasize again why health equity is so important. If we can move to the next slide. And this is some older data, but still true to this day, that 80% of health outcomes are determined by social, structural, and physical determinants of health. And that if you look at average life expectancy, Ward 3 has the highest life expectancy at 80+ years. Ward 8 has the lowest at 71 years. So again, these are really some of the disparities that we're working to address. So with that, I'm going to turn it back to you, Roxana, and we will get into the specific programs and hear from the amazing staff that's doing this work. Thank you so much.
Thank you, Kelly. Thank you for that overview. I think generally within our medical program, we strive to adapt to the needs of our patient population, and we've done so by incorporating some key positions, sort of like our nurse navigators, our care coordinators, and patient advocates. But traditionally, these positions have always been in the clinic setting and not in the community. So when the announcement for the CHW grant arose, I knew that it was just an opportunity we couldn't pass along. And so now I will turn it over to Emily to learn a little bit about our program. Emily, please introduce yourself.
Hey, good afternoon, everyone. Thanks, Roxana. My name's Emily. I'm the Community Health Worker Program Manager. My pronouns are she, her. I joined the team back in September of 2022, so about 3 months after we received this grant, and have been doing some great work since then. So I'm excited to talk more about it.
Thank you, Emily. And maybe we can just start by having you sort of tell everyone what a CHW is.
Yeah, that's a great question because obviously that definition can look different for different folks. And obviously, if you haven't been exposed to community health workers, you might not know what they are at all. And so the American Public Health Association is the definition that I really like. And they define it as a trusted member of the community that really has an unusually close linkage to that community. So really, when we were building this program, it was the idea that we wanted to hire individuals that really understood the community on a deeper level, that could really build rapport with patients and act as that link to the community as well as to our health clinic, so to their primary care provider.
And what needs are we currently addressing with patients? And tell us a little bit about how.
Yeah, and so as Kelly had mentioned, our grant is specific to working with DC Medicaid beneficiaries, and we specifically focus on patients with uncontrolled hypertension. So we obviously are addressing uncontrolled hypertension with patients, so uncontrolled blood pressure. And that might look like blood pressure education, how to take your blood pressure. It might even look like what your numbers look like and when you might need to contact your provider if there's something going on. But I think in this past year and a half, really what we've noticed is when we're having these conversations with patients, the biggest thing that's coming up is social determinants of health, right? And so a lot of times these social determinants of health are really the first thing that we need to address and talk about before we can even get to talking about blood pressure. And so I would say our top two social determinants of health that are really impacting not only patients on an individual level, but populations is housing insecurity and food insecurity. So a lot of times that was coming up first for us with patients.
And I imagine that it must be very challenging to try to address some of these needs unilaterally. So can you tell us a little bit about who we are partnering with to sort of address these needs?
Right. And our biggest success and kind of our first success was really integrating into the care team to sort of navigate some of those challenges that patients were facing. And so I think we had a really strong foundation within our own health clinic. So not only connecting with primary care providers, care coordinators, medical assistants, but also other team members like our emotional wellness services. And so once we were able to really integrate ourselves into the clinic, we were then able to connect patients to those appropriate resources within Community of Hope. And then I would say, as I had mentioned, food insecurity and housing insecurity continued and continues to come up, right, for patients. And so we actually ended up building a partnership with Arcadia Mobile Markets. And if you're local to DC, you may be aware of Arcadia. They're an awesome organization that has farmers markets throughout the summer, throughout DC, but focus in the wards that we serve, 5, 7, and 8. And so we were able to provide market vouchers for patients. Not only was it an access piece, right? Patients could access fresh produce and things like that, but it was also the opportunity for the community health workers to get out of clinic and provide some education on food, because blood pressure is tied to food. Know that those go hand in hand at times, the amount of sodium you're eating, things like that. And so that was a huge win for us, and a really important partnership. And the mark has actually just started up again, so we're looking forward to doing that again with patients this year.
Yeah, that was a really, really cool initiative. Can you maybe focus a little bit on our wins and talk to us a little bit about what outcomes have we seen in the past year and a half?
Yeah, we've certainly seen some pretty amazing things since starting this program, and it's amazing how far we've come also since we started enrolling patients. So about a year and a half ago, we've enrolled over 300 patients in the program across our 3 health clinics. And we have 4 community health workers in total across those 3 clinics. And so we've served over 300. We've graduated about 100 patients from the program, and we're just still kind of the initial pieces of data. And in regards to blood pressure control, which is of course something we're looking at, finding that the first sort of cohort that we worked with, about 60% of those patients that are enrolled in the program, they actually achieved blood pressure control within 90 days of working with a community health worker, which is a huge win.
Very impressive.
Yeah, and I think it just speaks to how important it is to have someone on your side and to really provide you with the tools that you need to thrive, especially with a chronic condition like hypertension. We did notice that it took time to obviously not only build this program, but also just to build rapport with patients, right? So I think initially we thought our interventions were going to be a lot shorter, maybe only around 3 months with patients, but we're finding that we're actually working with patients to closer to a year, which is not a bad thing. It's not a good thing. I think it's just something we're observing. It is something to consider, though, if we're thinking about sort of the long-term sustainability of the program over time.
So that brings me to my next question. So when you're thinking, as a program manager, when you're thinking about the future, what are just some of those opportunities that you see for growth or needs that you really feel we need to address?
Yeah, and that's a wonderful question, because I think there's so many opportunities for growth. I would say that the 2 pieces that come to mind for me are tied to insurance and chronic condition. So if we have the opportunity to expand to patients outside of the DC Medicaid beneficiaries, so uninsured patients, that would be huge, as well as additional chronic conditions like looking at asthma and conditions like that. So those alone would be easy no-brainers to expand working with people. And I would also say we focused a little bit, but not completely, on the overutilization of emergency room services, which we know in healthcare is directly tied to a population's health. If you're overutilizing emergency services, likely the health of that population is a challenge there. And so that's something I would love to focus more on, dive more into, and see where it takes us in the next few years.
And I'm curious to know or to hear from you, when you were building this team of community health workers, what were some of those key things that you were trying to keep at the forefront of your mind in hiring?
And as I mentioned, one of the biggest things was a community health worker was that trusted individual and trusted member of the community. So whether it's a shared language or shared chronic condition or just shared life experience, those are the things that are going to make people feel comfortable and really feel like they can open up to you. And I think that's what we've really found is with that direct linkage and connection to the community, we've been able to just provide some really holistic and really patient-centered care. And we've been successful with it, which is awesome. So I would say that has been huge. A lot of my job is focused on data and outcomes, but I think we have to remember that, there are people behind these numbers at the end of the day.
Well, thank you for saying that, because I think that's one of the things that we really do strive to do, and be very intentional in our hiring practices, which is, really truly trying to find individuals who represent the communities that we serve, that have a solid understanding of who our vulnerable patients are, through shared life experiences, and who may speak similar languages and who look like them. So thank you for sharing that. And actually, I think this is actually a good segue into our next panelist or participant. Malaysia, would you mind coming on screen, please, and introducing yourself?
Hello. Hi, Roxana. Good afternoon, everyone. My name is Malaysia. I'm a community health worker, pronoun she, her. I work at Conway, and I have been here and a community health worker for going on 2 years now. I love the role. I love what I do.
Thank you, Malaysia. So let's start by talking about what a day in the community health worker looks like. What does that look like for you?
Okay, so this is always a funny question to me. Is also a reason why I love this role. There's no monotony. So a day in the life is never the same, especially for a community health worker. I would say we have a diverse population, different challenges, similar needs, and all unique stories. The only constant in my day-to-day is my goal to help others and assist the best way I can. So what that looks like, it can vary. It could be linking individuals to and families to food resources, or giving them access to fresh food, as Emily mentioned earlier. It could be connecting patients to transportation, or assisting with scheduling internal and external appointments, linking patients back into care after an emergency visit or hospital stay. We also educate on topics like blood pressure and diabetes. It could be lending a listening ear, or advocating for patients, or teaching self-advocacy to show patients to use your voice. These are all examples of what we do as community health workers. So this is a typical day every day.
Thank you for sharing. And when you first started, you guys were mostly meeting patients in the clinic space. And then at some point you transitioned into completing home visits. What was that like for you, and stepping into someone else's home and trying to do this type of work?
You know, honestly, the biggest challenge wasn't going into the homes, it was making the patients comfortable enough to allow us or invite us in. Most patients, they they worry about being judged,
Mhm.
or not being comfortable in their environment and making sure others are comfortable. So the key to that was building a rapport, getting comfortable with them to the point that they were inviting us out. And it was such a healthy experience, because seeing patients in their own environment, you get to see more to the story. And I really enjoy doing home visits and field visits, because you see the patient for what they really are. You see them in their natural comfort zone outside of the four walls in the clinic, and it's just a rewarding experience and a great way to build that connection.
And you've been a natural at this. I think from the moment you came on, we knew that you were going to be exceptional in this role. So please share with us, what are some of those strategies that you have adopted to really establishing that trust with the patients that you've been working with?
First, thank you for the compliment. And it's a lot to do with the intentional hiring, and I'm glad that you also saw that in me as well. And the biggest thing is bringing my natural self, being the most authentic version of me. And just to relate to what Emily said earlier, a community health worker is someone that's a trusted member. So not only looking like the people that I serve, but sharing, having some of the same challenges, or even knowing the environment, knowing that there's a food desert, or how transportation runs, and I'm able to really put myself in those day-to-day challenges that they face. So when they look at me or speak with me, they're comfortable. They know you are just like me. And I say it so frequently that this is my community. These are my people. And it's the same for them. Just seeing someone that looks like them, but are advocating, are supportive, are not turning their nose up. And it's not to say that they don't get that in the clinic, but with such short time, providers don't always get that. So being able to go out and meet with them and say, oh yeah, I know this place or that place, and oh yeah, I understand why this is happening. That the connection is just, it's a peer connection.
Yeah, that's very important. I heard Emily say that, you have worked with patients for a very long time. What has that done to your capacity to see more patients?
That's a good question. And it's actually a challenging issue at one point, because I work at Conway and we have the largest population for chronic conditions. And when we first started enrolling, I'm enrolling, having this I need to help everybody complex, and my panel had gotten too big. So then I have individuals that are really complex that need so many resources and so much support, and I'm kind of neglecting other people, even though they don't need that much support, and they've taken the tools and used them, and they're great. It still doesn't feel fair. And I was so grateful, us as a team, we're grateful to bring on Ashley, our other CHW, because it really helped at Conway. So at the point where my panel got too large, I was able to pause and focus on all of the people that I am working with, and even start graduating people. So that was really fortunate.
Yeah, it is. We were pretty blessed to be able to bring Ashley on to sort of help you balance out that the need at that site. And I think that there's still a great need.
Yeah.
Yeah. So actually, I think this is actually a good transition to have you introduce our special participant today. So I'll let you do that. And thank you again, Malaysia.
Thank you. So, over the past year, I worked with a lovely patient, Ms. Zakiel Brown. Hi, Ms. Brown. Thank you for joining us.
Okay.
I can hear, we hear you. We see you. Yep. Hey, Ms.
Can you?
Brown.
I can't.
You can't
You
hear
can't
us,
hear
Ms.
me?
Brown?
Can you hear?
Oh, I think Ms. Brown, are you able to it looks like you're muted. Are you able to hear one of us? You may need to unmute.
Can you hear us? No.
No, she's having difficulty.
1 second.
Thank you for being patient, everyone. We're just going to try to see if we're able to get Ms. Brown back to share.
Hey, Malaysia, I unmuted. What's wrong?
Hey,
Malaysia,
Ms. Brown.
can you hear me?
I can hear you. So I have you on speaker so we can do it this way because you can't hear us.
Okay, that'll work.
You can mute your Zoom.
Okay.
Hey, Miss Brown. Thank you for being so flexible. Yeah. Okay, so we have you. Everyone can hear you. So I'm going to ask you a few questions, okay? All right. So
Oh.
again,
Malaysia, we can't hear her. I think she does need to unmute so that we're able to hear her speak. So we can't hear her. You may hear her, but we can't hear her.
can you hear her through my speaker? No?
And I did unmute. Can you hear me now? They
Yes,
can't
we
hear
hear
me.
you. We hear you well.
Okay, because I tried. Yeah, I did. It's not on mute. I took it off mute.
You're good, Miss Brown. We can hear you. Malaysia, you can start interviewing her if you want, or ask her some questions if you think I can.
All right, Miss Brown. So we recently spoke about our time working with each other and the impact it has had on both of us over the past year. And I remember telling you how I was nervous when I first met you.
Oh, me too. Because, I was the type that, well, you don't know yet. At first, I was the type that was scared to actually, say anything to tell my story. But as, as we gained respect for one another and you started talking to me more, I started opening up to you more. So I really still do appreciate that. You made me come out of my shell because at first I was like, no, I can't say nothing. I better hide this, because everything was new to me a year ago versus this year. So thanks for everything. I still appreciate that.
Aw. So I do have another question. You kind of like took it. Thank you. I appreciate all of our time.
Of course.
So I have a question. Though our program is focused on chronic conditions like hypertension and diabetes, we also assist with several other things. So in a sense of reality versus expectation, what was your initial thoughts about being enrolled in the CHW program? And what were you hoping to gain?
Just to get to know, new people, new faces, because everything was new to me at the time. When I first found out about Community of Hope, I knew nothing about it until I was introduced through a friend. Because I was like, I never, like I said, I never knew anything about it. I didn't even know it was this close to me until I was referred to, Community of Hope by this friend. And she said, you should give it a chance because it's right down the street from where you live. So I was like, I might as well, because at the time I really needed a doctor. And I was introduced to Dr. Tank. And through Dr. Tank, I was introduced to you through Dr. Tank, which was very helpful. I just wanted something new, but also it was a life-changing and life-saving situation for me. So if I had gotten down there in time, I probably wouldn't be here today. So I could still say, thanks to Community of Hope for everything.
Oh, Miss Brown, don't make me cry.
I'm serious, Renee. You know how I feel.
Okay, so can I ask you if you could share a specific moment where you felt a shift in your situation?
Malaysia, you may need to bring your earpiece down so we could hear you. We can't hear Miss Brown. Miss Brown, did you hear the question?
Miss Brown, they can't hear you. No, not on the Zoom anymore.
Okay.
Yeah, I don't think anyone else can hear. No.
Do I need to do something?
You're good now. We can hear you.
We can hear you.
Oh, you can hear me? Also, now what was the question again so we can go back over it?
I was asking for you to share a specific moment where you felt a shift in your situation for the better.
Oh, when I was introduced to Dr. Tang.
My older brother and the whole of my life. He has really did change my life. I got down in time, I wouldn't be here.
Yeah, I can hear you, but did you walk away from your computer?
That's probably right there. I had to get something.
Can you hear me?
Yeah.
Can they hear me?
Yeah.
So they heard what I said? Oh no.
Yeah.
Okay.
One more question. Ms. Brown, how would you say the community health worker program or our interactions assisted you in understanding and managing your health?
You, if it wasn't for you. And to be honest, Malaysia, if it wasn't for you, even volunteering to go to my appointments, sit with me through my appointments, I am grateful. Because if it wasn't for you, I truly, truly don't think I would have gotten through this if it wasn't for you. Your talks, you know, everything. You listening to me, being a listening ear, just being my angel. If it wasn't for you, like I said, Malaysia, I don't think I could really, really, truly push through this.
Oh my goodness, God.
I'm serious though, Malaysia, I am. Because, you know, like I said, sometimes last year I felt like giving up. But because of you, I refuse to give up. I say, Malaysia said I could do this, so I know I can do this. And I did it. But because of you, I was able to get through this. So I am grateful. Malaysia, I truly am grateful. Because you're my angel, and I really, really, truly, truly appreciate you.
You're really about to have me crying.
No, Malaysia, because you remember when I first met you, I was a nervous wreck. And you got me through this. You just, everything, being honest with me, just your encouraging words really have got me through a lot of things. From last year to this year, I can say I'm 100% better than I was last year. Because, you know, everything I went through last year was hectic. I thought that last year was going to be it until things started looking up. And then this year, they really started looking up. And I always share my good news with you. Once I get my good news from my doctors, I always give you my good news.
Oh, Ms. Brown, thank you so much.
I appreciate it.
And this is why this program needs to be here.
Yes.
This is why I love it. So thank you.
No, thank you.
Thank you for working through the technical difficulties.
No problem. I just want to make sure that everybody knows if it wasn't for you, I don't think I could have pushed through this. And I'm honest, Malaysia, I really am. And I'm not gonna get on your nerves no more, because until I come down the street, or I'll call you. Other than that, I am truly, truly grateful, because I know you'll always be there for me. Always.
I will.
Most definitely, I know, Malaysia. No problem. I appreciate it. I said I would do this for Malaysia. I made sure that of course, no problem. I am grateful. Truly am grateful.
All right, we're not going to take up too much of your time, so I appreciate you joining us.
No problem. I am grateful.
I'll see you soon.
Yes. Well, I'll be down there Friday, but I'm going to the dentist.
Okay.
But I will be down there next Friday. All right, Malaysia. Thank you so much. Bye-bye.
Thank you, Malaysia, and thank you, Ms. Brown. So we are going to invite all our panelists to return back on screen. Thank you, everyone who was listening in, and for the through your patience for our technical difficulties. We do have a couple of questions that are coming on. So the first question is, do you all see individuals becoming more comfortable, open to seeing providers in the office as a result of their connection to the CHWs? I think I'm going to ask Malaysia to answer that.
All right. Sorry, Roxana, can you ask again? I'm over here bawling. I'm sorry.
Malaysia, I'm crying and laughing as well. So
Yeah.
yes.
Yeah. So the question was, do you see individuals becoming more comfortable and open to seeing their providers in the office as a result of their connection to the CHWs?
I do. Our team teach a lot about building a rapport and staying consistent with a provider. Even supporting, hey, if this provider isn't working, let's find someone else. Let's, give them a try. Oh, they'll listen, tell them what's wrong. And a few appointments we've sat in with patients, or they'll call and ask us, can you tell me again what am I supposed to ask for? Or, oh yeah, you mentioned to me this. Tell your provider. And they are being a little more comfortable.
Thank you. A second question we have are, and honestly, I think Kelly, Emily, myself, any one of us can answer. What are the prospects of expanding the CHW program? I don't know who wants to take a shot at that. I mean, I think we're actively working. Yeah, it's a hard question. I think we're actively working on
very
that.
top of mind. I mean, as you can see, it's an incredibly impactful program. So a couple of things, we are pursuing some philanthropy. We should hear shortly about some funding for that, because we really think this is an important program. Again, we're very grateful to DC Health for this pilot program, and that funding does end at the end of September. So we continue to look at fundraising to really help us innovate and grow and develop. And then the long-term solution is really going to have to be around Medicaid and thinking about what kind of advocacy, how do we use data from this pilot to really help inform those conversations. And that's really going to have to be the next step for the long term.
Thank you, Kelly. Another question we have is, and I think this one would be maybe better for you, Emily. How long is someone's blood pressure stable before they graduate? Do you track patients after they graduate from the program to ensure their blood pressure stays stable?
Yeah, that's a great question. So the workflow that we created was, once patients achieve blood pressure control after 3 months, we consider graduating them from the program. And the reason we did that is because our model in Community of Hope already is if a patient's blood pressure, reaches control, they won't be due back into clinic until 3 months. And so that's kind of where that stemmed from. I would say after the fact, if the patient's blood pressure, falls out of control again, there's still opportunity to work with that patient. They're going to be in clinic. We are here in clinic. And so Malaysia, I feel like the conversation doesn't stop just if you graduate the patient from the program. Like, you're always going to be a resource for them, and you're always going to be there to support them if they need assistance. So it continues, I guess, is what I'm trying to say.
Mm-hmm. And I think one of the things that we also, and part of the work that we tried to do for the integration, was having the CHWs identify patients who really need more complex support or more tailored support. And so I think our CHWs are also a way of being able to refer patients to our more traditional care management program, where they can be followed by a nurse or a care coordinator. And there isn't such a, short-term interval. We work with them for the long term. Okay, another question that has come up is, how can community members get connected with CHW?
I can take that one as well. So because of our grant, we're currently working with Community of Hope patients. And so again, our model is that we enroll patients who are Community of Hope patients. Certainly community health workers across the country, across the world, have different models in which they might be in the community outreaching to people to either get them into a clinic or provide them services regarding, a chronic disease or something like that. So I would say, if you are a Community of Hope patient, we will be connected to you at some point, and that's our model at this point.
Okay, thank you. Another question, and this one's probably best for Malaysia. Are clients as receptive to medication as dietary education and change?
Clients would much rather do lifestyle changes than medications. Now, there are people who have been medications majority of their life and they're just used to it. It's just another pill. But some are really interested in, I want to get rid of it. If you get on medication, you're never coming off. And we do teach them that that is not the case. That's a myth. You can control it. And with lifestyle change, you can maintain it. But especially with all of the resources that we have, like cookbooks and measuring spoons and the market, I've seen personally just them changing how they eat is doing much more than medication adherence, because the providers can prescribe all day, but if they're going to consistently take it is the question. But they can manage what they have to do multiple times a day, which is eat. Even using the resource like the Centering Heart Health group, where they were learning from Kathy, our nutritionist, about salt. And my patients that attended really took away from that. So lifestyle changes are like more the route where more of my patients would like to go rather than medication. But so many people have gotten on medication and were consistent, and now they don't have to take it anymore.
And I think one of the challenges with the lifestyle changes has been access to fresh produce, right? And because at least in some of the wards in which we serve and where the majority of our patients live, we recognize there's a food desert. So getting access to that has been very challenging, which is why the Arcadia initiative was very successful and has been very sort of therapeutic and helpful for our patients. Thank you for that. Okay, so we have another question. How many community members are enrolled in the program currently?
We have a little under 185 currently enrolled at this point across our 3 sites. And again, in total, we've served over 300 patients and have graduated about 100. So if my math is correct, it might be a little off, but yeah, sub 200 at this point. Again, we consistently are graduating patients and enrolling new patients. So that continues it changes, I guess, on a day-to-day basis.
Hey, Emily, people often have questions too about how big the caseload is. And in Malaysia, I know you said at one point it was getting way too big and then it got more manageable. Maybe you could expound a little bit about what kind of numbers per person makes the most sense.
Sure. So at one time, my panel was at 86 people. Yes, a lot. But I'm not at that number anymore. We had a lot of graduations. I'm proud to say we had 6 graduations last week for just my panel alone. So yay. And that was due to patients being managed and blood pressure being controlled. So we are not trying to get back up to that number, but we just understand the need. So we have done really great work at helping one another and trying to spread the work evenly. Again, shout out to Ashley. Ashley being at Conway has been such a big help. I can graduate more and she can enroll more.
Do you have an optimal number of what the right size is?
I think 40 is really manageable. I think 40 because like every week someone's graduating, really. So 40 is a good number. So half of what I had, I think 40, yeah.
And I think Malaysia also is something that we talked maybe a little bit about, but it's also the complexity of, what a patient is experiencing. Like you have some patients that might not need as intensive support as others. So that also plays into it. Is it just high blood pressure you're supporting with, or is it that they also are facing housing insecurity? They're also needing access to food and childcare and etc.
Yes, it is that. And I think we mentioned earlier that because they get so much support, I've had a time graduating people because they would not want to do like the exit survey. They did not want to graduate, a fear of losing support. So now we say, like, you can still call us. I still work here. I can still navigate you to different things. You didn't lose a resource, but you can manage on your own now. You're good. I'm confident. So yeah.
There's one question, and I think I can take it. It says, does the CHW program serve families in addition to individuals? And the answer is yes. So, if a participant meets the criteria for enrollment, we not only work with the patient, but with their family members, because we also work with kids. And so when you're working with kids, you're also having to work with whoever is cooking, at home, and sort of is going to take lead in making some of those decisions. And so for some of our patients, it's also about getting their support system in place and also on the same page. And so, yes, we do support families. I also have one question on the intersection of pregnancy and hypertension with the CHW program. I think I can maybe answer a little of that, maybe at least partially. So currently our prenatal model is that we don't necessarily care for high-risk pregnancies through our midwifery program. And so a good amount of our patients who potentially have been diagnosed with hypertension would probably be risked out of our midwifery services. But it doesn't mean that a CHW can't work with a pregnant patient on developing healthier eating habits and lifestyle changes. So we wouldn't be able to manage the prenatal aspect of it, but I think the hypertension piece, if we were the primary care provider for the hypertension, we could at least provide that support. Okay. I think that's all the questions I see so far, unless anyone else has.
Yeah. So I just want to sort of start wrapping us up. And first, I miss having the chats and the reactions, because what an amazing team. And I know everyone else is agreeing. In fact, there was one comment that one of our participants wants to reiterate how wonderful this program and this community health worker team is. Keep doing all the amazing work that you do. Community health patients are so fortunate to have you all. So I want to echo that. Malaysia, you are indeed an angel, and I too was crying, and how amazing a gift you are to so many of our patients. Emily, you have done a wonderful job starting this program from scratch and getting it up and running and organizing, collecting all the data. And Roxana, as always, you are a wonderful leader and visionary. This was your vision. We worked together on the application program. And so it's just been wonderful having you in that leadership role, and everybody else who really works and supports this program. Just if you're saying, well, what can I do to help and to get involved? We certainly welcome you to continue to help us think about how do we advocate for some policy changes. If people have suggestions and thoughts, please do reach out to us here. If you're interested in getting involved through volunteering, our website, communityofhopedc.org, has information about how to volunteer. And then last, but certainly not least, we welcome your financial support through our Hope in Action Fund. That provides general funds to help us with programs like this, to help add other items or client support, or help fill in funding gaps when they come in. And again, you can learn more about that at our website at communityofhopedc.org. Thank you so very much for joining us today. I hope you learned something new and were as inspired as I was, and continue to be with this amazing team. And just thank you so much. Enjoy the rest of this beautiful day and have a wonderful weekend.
Thank you, everyone. And thank you, Kelly.
Thanks, everyone.
Thank you all.